Good afternoon, Dr. Sangeeta.
Good afternoon, Dr. Rishi. Thanks for joining in. So we are just starting. I'm handing over to Dr. Suroj and I'll invite you.
Uh, a very good afternoon to all the participants for today's clinic, and it's my privilege to welcome you all to our esteemed pediatric TB Eco Clinic, which is organized in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. It is my privilege to extend a heartfelt greeting to our DDC ma'am, Dr. Vashi Singh ma'am, and her team, as well as the directors and team from pediatricians, state TB officers, nurses, faculty members from medical colleges, medical officers, pediatric TB experts, and every participant who is joining us today. Today's clinic aims to highlight the challenges in the management of TB patients and will provide the insights into the approach and management of non-responding TB cases. Let me introduce the faculty from NITRD for today's session. To my immediate right is Dr. Sangeeta Sharma ma'am. She's former director of NITRD, consultant pediatrics, and in charge of National Center for Excellence for Pediatrics, TB and DRTB at NITRD. To my extreme right is Dr. Alok Yadav sir. He is working as a Chief Medical Officer, NFSC, in the Department of Pediatrics at NITRD. And I'm Dr. Saroj Meena, chest specialist at NITRD, and it is my honor to moderate today's clinic session. As Dr. Tulika, she is not well, so she is on leave today. To officially begin with, now I invite our DDC ma'am, Dr. Urvashi D. Singh ma'am, to address today's clinic. Over to you, ma'am.
So, at the outset, I would like to thank NITRD, Dr. Sangeeta Sharma, the former director of the institute, Dr. Upasna, the current director, and the whole team that puts this, painstakingly puts difficult to treat cases and brings out several gaps which may happen in the treatment, diagnosis, and the management, follow-up, etc. So, Dr. Sangeeta, kudos to you and your team that you've maintained this difficult to treat pediatric clinic for more than a year now. You celebrated your anniversary, 2 months back. What we acknowledge is that your effort to conduct a continuing medical education for all our partners, our NTP teams across states, across districts. Several district TB officers are also joining. Often we have seen several medical officers across the country join. And a lot of the NTP the teams at state level learn from your efforts. So, today what you're covering is a topic of great importance that one, of course, disseminated TB in children can be difficult to diagnose because there are several differential diagnoses which may confuse the diagnosis of TB, and often the patients, if not followed up carefully, can be lost to treatment under the care of the pediatrician. And like I said earlier, dissemination especially can confuse the diagnosis with other differentials. What is important is to reach a definite diagnosis. And what we have been stressing with our state TB officers, our district TB officers, our state teams every now and then, that frequent follow-ups, as has been recommended under the guidelines for years together. This is nothing new. That the patients should continue to follow up during treatment at least 2 weekly. And in BPAL M also, we recommended at least once a week meeting should be continued, once a week follow-up should be continued. And post-treatment follow-up for at least 2 years, so that relapses, if they occur, are brought to the notice of the treating physician at the earliest, so the patient does not become, further complications may not appear. Patient may not progress from pulmonary to an extrapulmonary TB or progress to an MDR TB. Such care can be offered within the existing guidelines if those are followed carefully. Also, several publications from within the country have brought out the drug levels not reaching optimal. In adult TB, there are papers from AIMS, from my group, from NIRT. In children, there are papers again from Dr. Sangeeta has led some publications on therapeutic drug monitoring, some papers from AIMS, again, some from NIRT, and pardon me if I'm missing quoting a few papers. But there is a lot of work around drug levels not achieved and hence non-response of the patient to treatment. The program is looking at this problem also proactively, and we'll soon come back with a solution for this. With these words, again, thanking the team from NITRD and for all our senior experts who have joined us and all the medical officers from all over who have spared the time to learn from the team and from the case today. Thank you. Over to you, Dr. Sangeeta.
Yeah, thank you, Dr. Urvashi, for your encouraging words. You at the helm of the NTEP in charge. I'm really, I always acknowledge that the program is doing kudos. We are doing, you're doing a lot of hard work, and we are seeing the results. So that encourages us to, carry this pediatric TB eco also on the same lines, because it's meant as a teaching and session where we learn from each other. So thank you for your words of encouragement. So now, Dr. Saroj, please carry the session forward.
Thank you, ma'am. So today's case presentation will be done from the Department of Pediatrics. The case will be presented by Dr. Gayatri Krishnan. She's a postgraduate student at RSR RML Hospital. And Dr. Komal Kadian, she's a senior resident at RML Hospital. We deliver a didactic session on DRTB, drug resistance TB, missed or misdiagnosed cases. Dr. Hema Gupta, professor in charge, Pediatric Pulmonology Division. Dr. RML Hospital, New Delhi, will be the expert for today's case. And the national expert for today's clinic will be Dr. Sangeeta Sharma, ma'am, senior consultant in the Department of Pediatrics and ex-director of NITRD. So let's begin with today's case presentation. And now I invite Dr. Gayatri Krishnan to begin with the case presentation. Over to you, Dr. Gayatri.
Just one second. Is the screen visible?
Yes.
Good afternoon to one and all present here. I'm Dr. Gayatri Krishnan, and today, along with my SR Dr. Komal, and under the guidance of Dr. Hema ma'am, we will be presenting a case of an interesting case of an adolescent on anti-tubercular therapy. Here we have a 14-year-old male child who's presented to us, who's hailing from Delhi, who's admitted outside, presented to us with complaints of right-sided chest pain, fever, loss of appetite, and loss of weight since 10 days. The chest pain was right-sided, insidious in onset, moderate in intensity, sharp in character, and worsened on deep inspiration. Fever was low grade, undocumented, 1 to 2 spikes per day, more in the evening, and not associated with chills and rigors. Appetite of this child was markedly reduced, and child also had loss of weight of approximately 1 kg. Now, the child did not have any history of shortness of breath, cough, hemoptysis, trauma, no palpitations, no joint pains, no swellings, no lower limb swelling, no bluish discoloration of lips or nails, no bleeding or rash from any side, no paleness of the body, no nausea, vomiting, or no pain abdomen or distension. Child did not have any previous admissions, no similar complaints in the previous complaints, or no prolonged illnesses. Antenatal and birth history was not significant. Developmentally, child was appropriate for age with an average scholastic performance. Child was from a non-consanguineous marriage, first in birth order, with no contacts, TB contacts, and no history of chronic illnesses. On preliminary investigations, which were conducted outside, child was seen to have an HB of 9 grams with a TLC of 6,600, a DLC which is predominantly polymorphic, a platelet count of 1.6 lakh, and LFT, KFT, and serum electrolytes were within normal limits. Chest X-ray done outside showed minimal pleural effusion with infiltrates. A pleural tap was done, which showed a TLC count of 1,500 with predominantly polymorphic picture, sugars less than 10 milligram per deciliter, proteins of 5.2 gram per deciliter, and albumin of 4 gram per deciliter. A TB workup was done outside with induced sputum and pleural AFB and CB-NAT, which was sent. Montox was done, which showed an 8 mm induration. Pleural fluid gram stain and culture was negative. Now, all of the TB workup was negative. Child at this point, after a hospital stay of 2 days, was discharged with a provisional diagnosis of right-sided pleural effusion, query bacterial, query TB with anemia. Child was discharged on oral amoxicillin and asked to follow up after 5 days or in case of any worsening in OPD. Now, the child presented to us for the first time in emergency after 1 month of these complaints with persisting right-sided chest pain, with mild breathing difficulty and fever. Now, child had new symptoms of pain in the lower back since 1 month, weakness in bilateral lower limb since 4 to 5 days, and tingling sensation in bilateral lower limb since 3 to 4 days. The pain in the lower back was mild, worsened on lying down, relieved on sitting, with dull aching, no radiation. Weakness was insidious and onset gradually progressive. Child had difficulty in walking, in wearing slippers, and getting up from squatting position. Child had no truncal weakness and no upper limb weakness. The child also had bilateral tingling sensation. Child had no history of cough, hemoptysis, palpitation, lower limb edema, no masses or swellings in the armpits, groins, or neck, no bone pain, no rashes, no joint pain, no mucosal ulcers or trauma. Upper limb, there was no upper limb weakness or truncal weakness. Bowel and bladder disturbance was not seen. Sensorium of the child was normal. Child had no abnormal body movements, no headache, vomiting, or neck stiffness. There was no blurring of vision, no signs of any cranial nerve palsies. Child also did not have any history of recent GI infections, no recent respiratory infections. In the last 4 weeks, child had no IM injections or any vaccination. On examination, child was afebrile with a temperature of 98.7 Fahrenheit, pulse rate of 84, and with mild tachypnea of 26. BP was 110 over 72 mmHg. Extremities were warm. Anthropometry, child was underweight with a BMI of 12.8 kg per meter square. Head to toe examination showed mild pallor. There was no icterus, cyanosis, clubbing, or edema. Child had multiple subcentimetric lymph nodes in bilateral cervical, which were matted, non-tender, and mobile. Systemic examination. In the systemic examination, respiratory system showed decreased movements on the right side of the chest, decreased chest expansion on the right side of the chest. Tactile phlegmatis was decreased in right side, stony dullness, and decreased air entry in the right infraaxillary, inframammary, and infrasubscapular areas. Cardiovascular area system and per abdominal examination were within normal limits. Central nervous system examination showed that the child was conscious, oriented to time, place, and person. High mental function was intact. Cranial nerves were normal, and pupils were bilaterally reactive. Motor system showed that the bulk was bilaterally symmetrical, but tone was increased in bilateral lower limb. Power was decreased in bilateral lower limb with brisk DTRs in the knee jerk and ankle jerk. As we can see, the power was 2 by 5 at the ankle, 3 by 5 at the knee, and 3 by 5 also at the hip. Superficial reflexes, the abdominal were absent. Plantars were bilateral upgoing. Sensory system examination showed decreased touch and pain below the umbilicus at around level 10, T10. Spine examination showed a gibbous on the lower back with tenderness present in the same area. Child had no meningeal signs, no cerebellar signs. Now, investigations at this point showed a relatively normal lab parameters. Hepatitis B, C, and HIV were non-reactive. Chest X-ray at this point showed that there was an increase in pleural effusion compared to the previous X-ray. Now, a provisional diagnosis of right-sided pleural effusion with compressive myelopathy. Query secondary to port spine, Cox with port spine was made. Child was planned for MRI spine, CECT chest, and ultrasound whole abdomen for dissemination. MRI spine showed there were diffuse enhancing collections in the postal epidural space from D5 to D11, and also in the prevertebral and bilateral paravertebral space with collections of 1 centimeter to 1.5 centimeters. And there were also features of compressive myelopathy. The MRI spine was suggestive of infective etiology, query tubercular. At this point in time, we have a child with multiple system involvement with both respiratory and CNS infection, but which was suggestive of tubercular etiology, but with no microbiological evidence. Now, we followed up with bronchoscopy. Bronchoscopy findings revealed, as we can see in the video shown, that the child in the lower trachea had right side collapse, query and external compression. The left bronchial tree was normal. The right middle bronchus was obstructed. The right upper bronchus and the right lower bronchus were normal. Bowel samples were sent for AFB, CBNAT, and MJIT. Now, the bowel sample CBNAT was positive for MTB with rifampicin sensitivity, which was detected. Now, after a 10-day of hospital stay, a final diagnosis was made of disseminated Cox with microbiological evidence, pulmonary and extrapulmonary involving pleural and port spine with compressive myelopathy. Child was started on ATT with steroids. For the compressive myelopathy, neurosurgery and ortho consultation was done, and conservative management was advised. Child was discharged and followed up in DOTS and TB clinic. After 2 months, child showed weight gain, gain in appetite, improving motor symptoms and sensory symptoms, and continuation phase was started. To summarize the story till now, we have a child who presented with a chronic history of fever, chest pain, loss of appetite, and loss of weight, which is suggestive of TB, with multi-system involvement involving pleura, spine, and pulmonary, who had a confirmatory microbiological evidence by CBNAT and with drug-sensitive status, and the child showed improvement on starting ATT. After this point, the child was lost to follow-up. Now, after this, the child presented to us again in a third admission, which was 3 months later. Now, 3 months later, the child had new complaints of loss of appetite and loss of weight, bilateral neck swelling, and an acute complaint of difficulty in breathing and swelling over the body, which was 1 week and 5 days respectively. The bilateral neck swelling, which has been present since 3 months, was insidious in onset, gradually progressive, with no pain, redness, or discharge at any site. Child also had difficulty in breathing, which was insidious in onset and gradually progressive, with an MMRC grade 1 to grade 3, which worsened on lying down. Parents also noticed child slowly had swelling all over the body, which initially started in the bilateral lower limb, progressed up to the abdomen and chest, and to the face. Now, child did not have any fever, cough, hemoptysis, palpitations, or PND at this point. Child also did not have swelling, masses in the armpits, groins, no bone pain, no night sweats. Child did not have rashes, any joint pain, no mucosal ulcers. There was no history of any decreased urine output, no red colored or cola colored urine. Examination showed that the child was afebrile. Child had tachycardia and tachypnea. A pulse rate of 140 was noted with a respiratory rate of 30. BP saturation was maintained. Extremities were warm and pulse volume was normal. On head-to-toe examination, child was found to have pallor with facial puffiness and bilateral pedal pitting edema. Lymph node examination, where previously child had subcentrimetric matted lymph nodes, now the child was noted to have multiple lymph nodes in bilateral cervical, submandibular, and postauricular region, and also in bilateral linguinal region. The difference was that the child now had firm, non-tender, non-matted lymph nodes. Respiratory system examination showed similar findings as before, but the air entry was further decreased. Child now had decreased air entry in bilateral, axillary, intramammary, infrascapular areas. Per abdominal examination showed a difference with soft, non-tender, distended abdomen, but liver was palpable 5 centimeter below the costal margin with a liver span of 10 centimeters, which was firm in consistency. Spleen was also palpable for this child, which was 3 centimeter, which was firm. Child had shifting dullness with no fluid thrill. Bowel sounds were present. Cardiovascular examination and central nervous system examination were within normal limits. Investigation showed an HB of 12.7 and platelet count and TLC were normal. Peripheral smear showed normocytic, normotropic RBC with no atypical cells. HIV, hepatitis BC were normal. LFTs and KFTs were normal. A repeat X-ray at this point in time, as we can notice from the serial X-rays, child is currently having a massive right-sided pleural effusion with a mediastinal shift to the right. Now, on reviewing the child, we can see that the child who initially had a resolution of symptoms with improvement has now presented to us with new onset loss of weight and loss of appetite. Child is also having new onset of generalized lymphadenopathy, firm hepatosplenomegaly, and increasing pleural effusion. Now, in a high TB burden country like India, in a child who has already been on ATT, the first thing we must all consider is drug-resistant TB. Even in a child with who's compliant to ATT or with no new contacts of drug resistance, we must always consider drug-resistant TB. But this child also had increasing pleural effusion, but no history of fever. Another differential that we considered is this TB iris, which is a paradoxical reaction. But child had lymphadenopathy, which is firm, and fever was absent. We also considered if this could be any immunodeficiency, which is acquired, but HIV was negative. Now, as we planned further, we planned for pleural fluid analysis, bronchoscopy, and lymph node FNAC. Now, for the pleural effusion, a pleural tap was done, which showed a hemorrhagic fluid, which is non-dramatic. An RBC in the pleural fluid was seen from 19 to 20 per high power field. TLC of 1000 was seen, which was predominantly lymphocytic with a lymphocyte count of 95%. We can see the post-pleural tap X-ray on the right. Now, for diagnosis of drug-resistant TB, a repeat bronchoscopy was done. Now, bronchoscopy revealed, as we can see in the video, a left main bronchus narrowing with query external compression. As we can remember, the previous bronchoscopy revealed a right-sided bronchus compression, specifically in the right main bronchus. Now, in this repeat bronchoscopy, after 5 months, we can see a left main bronchus narrowing. Is this a new onset left-sided, which is due to progressive TB? Bowel samples were sent for AFB, CBNAT, and MGIT. Child was planned for CECT chest. Bowel CBNAT at this point was negative. ATT was continued for this child with oxygen support and symptomatic management. Child showed no clinical improvement. Now, at this point in time, we have considered drug-resistant TB, and with previous microbiological evidence, we have reviewed the child with repeat bowel samples to see if there is any drug resistance or if we have to consider anything else. Now we can see that the child had initial improvement, followed by new onset loss of weight and loss of appetite. Child is compliant to ATT, no TB contact with repeat bowel negative and no fever. Child also had firm lymphadenopathy with firm hepatosplenomegaly. Could this be something else like malignancy or some fungal infection? Child was planned for lymph node biopsy, bone marrow aspiration and biopsy, and repeat peripheral smear and CCT chest. Now, CCT chest and abdomen was done, which showed multiple centrilobular nodules, few of them showing tree bird appearance in the right lung parenchyma. There is also, as we can see, massive right-sided pleural effusion with passive collapse of the underlying lung with mediastinal shift towards the left. We can see here that there's an anterior chest wall invasion and thickening of the posterior pleura, right more than the left. An ill-defined area of consolidation with air bronchogram was also seen, query secondaries in lung. We can also see that there are lobulated hypoenhancing homogeneous lymph nodal masses in the mediastinum and retroperitoneum, causing an encasement of vessels. A bone marrow aspiration biopsy was done, which finally revealed that the bone marrow aspirate showing blasts and which were MPO negative blasts, and this was seen to be an MPO negative acute leukemia, which was B cell ALL. A repeat peripheral smear showed that DLC of 30 DLC with blast of 19,000 and platelet count had dropped compared to the day of admission with thrombocytopenia of 50,000 and peripheral smear showing blasts, and a final diagnosis of disseminated Cox pulmonary with severe extrapulmonary TB, pleural with port spine on ATT in continuation phase with MPO negative B cell ALL was made. ATT was continued for this child. Child was transferred to hemato-oncology and induction therapy for start of B-cell ALL was done. Now I hand over the presentation to Dr. Komal, my SR, who will continue with the discussion.
Dr. Gayatri, we can take questions from the audience from the history. House is open.
Everyone.
Question. We can take questions now based on the history.
Good afternoon, everyone.
Are there any questions from the house?
Dr. Sangeeta, if you may, if I may, with your the chair's permission.
Yes, please. Yes, ma'am.
Why was the rest of the diagnosis not tried? I mean, the differentials not ruled out at the outset. You know, this has been discussed in several meetings that the coexistence of cancers and TB should always be considered. So the same sample or samples that were drawn could have been tested for, you know, ruling out the other diagnosis. So that was my question. Why did we not think of ruling out differentials using the samples we collected at the baseline?
I mean, I can just add one thing, you know, when the pleural fluid is not improving, even in such a case, we recommend to do an ADA. You know, because that also sometimes tells us whether this pleural effusion, which is increasing so rapidly, is it due to malignancy or is it because of tuberculosis? So it's a good, normally we do not recommend ADA for pleural fluid or for CSF. But for non-responders, it's a good idea to, you know, go ahead with the ADA to differentiate malignant pleural effusion from tubercular pleural effusion. So, Gayatri, can you answer the question? Or Dr. Hema, our DDG ma'am wants to ask why.
So good afternoon. Good afternoon, everybody. So I think it's a very valid query which has been raised by the ma'am. So initially we saw that the child presented with pleural effusion, and then the child developed neurological symptoms, and then the child was also microbiologically positive. So there was no question that the diagnosis was pulmonary TB because it was microbiologically positive and it fitted with the clinical scenario also. The child also improved with 2 months of antitubercular therapy and then was later shifted to continuation phase. So far, we did not have any query that the child did not have tuberculosis, and we did not thought of anything else because the child was microbiologically positive and the child also responded to the antitubercular therapy. Now, it is actually during the later phase, after 3 months, that the child started deteriorating and had new onset of symptoms which were different from the previous one. So it is not that the child did not have tuberculosis, it is that there was a second thing which added to the disease. We don't know when it came in, whether it was from starting or popped in after the coordination phase. And then the child had different manifestations which were clearly indicated that this was not tuberculosis but something else. Because we see even in the second presentation, the child did not have any fever. So once you think about tuberculosis or drug-resistant tuberculosis, we know that the child is systematically ill, the child has fever and all those symptoms. So the child did not have these symptoms, and it clearly indicated that the child may be having something else. So I think there was no query that the child did not have TB, and we had another diagnosis in mind when we started the case.
The other thing which is very interesting in your case, you know, it started with a hemoglobin of 8, and with treatment, you know, the hemoglobin pulls up to 12. And I mean, that time also the CBC picture is not suggestive of any leukemia. You know, it's the counts are also within normal. I mean, platelet count is initially it was more than 1 lakh, and I think even in the second time it was above 1 lakh only. The TLC was also normal. There were no blast cells in your peripheral blood smear. So, I mean, I feel it is fair enough, you know, that you considered it was only tuberculosis because there were no other findings, you know, there was no lymphadenopathy or hepatosplenomegaly. All these things they build up with time. So initially, the diagnosis of tuberculosis, even I would have done in the similar manner, but only in the cases. Yes, please, ma'am.
Come in. None of the scans suggested any additional diagnosis. You see, in adults, we have, we have had one session in the previous difficult to treat TB clinic where we actually discussed that the two could coexist. Carcinomas with
Yes.
all kinds,
Yeah.
cancers along with TB. So my suggestion was only to, bring out, did we miss anything? But maybe in the scans, also to drive the point that we must be on the lookout for, comorbid conditions and especially, cancers along with TB because they will, it's ideal to actually rule out both. So were the initial scans did we miss something or we just ascribed it all to TB and not look for so any comment there?
So, yes, ma'am, thank you. You have a very valid point. But as far as the pediatric TB goes, the diagnosis in this case was a microbiologically positive TB, which was actually clinically correlating, and the child was also responded to the therapy. We did not have any reason to do a CT in the first time because the child was already proven as microbiologically, and there was no other differential diagnosis at that time. It is the CT was planned later when we see that there's a lot of compression which is there, which may be possibly because of a mediastinal necrotic lymphadenopathy. And CT scans generally are not recommended unless you have something in mind. So it was later when the worsening was there, we repeated a CT scan, and all the findings were consistent with tuberculosis, except that yes, now we thought of secondaries of tuberculosis, and the child had some kind of a pleural thickening, and then secondary something there, and even an abdominal secondaries. So it is not there that we missed tuberculosis in the first, we missed the carcinoma in the first attempt. Actually, it came in later in the part of the disease. So I can't say whether a first CT would have given me an additional diagnosis, but yes, in routine recommendations, we don't advise a CT scan of chest in all cases of pulmonary TB also.
But you did an endoscopy, you did a bronchoscopy.
Yes, ma'am. Yes, ma'am.
And often, in fact, I'll bring the discussion to the point where microbiological diagnosis in pediatric TB, this was an older child, it may have been simpler, but in a younger child, it's often non-parenchymal, only mediastinal involvement may be seen. In which case, you not get a microbiological diagnosis. So again, open to the pediatricians to actually further think whether if you can take an invasive technique, right? Something like a bronchoscopy, which you're ready to subject a child to. Would you like to have a scan prior, or maybe in your algorithm you include such a test? Maybe you could have picked up the mediastinal, lymph nodes, and they could have been suggestive of any other pathology other than TB as well. Because like I said, in younger children, you will possibly not get a microbiological diagnosis of TB because the sensitivity of gene expert in mediastinal involvement doesn't cross in all pediatric, it doesn't get better than 40%. If we use ultra or further refined methods of, there are a few papers when you look at you pool white blood cells and do gene expert after treating them. Possibly the diagnosis improves. The bottom line of what I'm saying in pediatric TB, diagnosis with gene expert also is not equivalent to the gene expert yield in an adult population. Meaning that by all children with mediastinal TB, before you offer them an invasive test, may be ideal to at least run a scan which is less invasive. You can look at the algorithm, amongst all you experts. Please carry on.
And a CT scan would have given us the diagnosis of a mediastinal lymphadenopathy, which again, whether it is tuberculosis or a malignancy, would have required again a FNAC, possibly through EBUS or something like that. So bronchoscopy.
Maybe a PET, maybe if you found you didn't find necrosis, but some other presentation. No, I'm just suggesting maybe this could be part of the algorithm. If it is helpful, maybe a PET following a CT, if it is doubtful. It is less invasive anyway. We are talking of a tertiary care center, right?
Your points are really well taken, ma'am, Dr. Urvashi, because I mean, one should always have differentials in mind. But considering how they kept the child on follow up, I feel Dr. Hema, you also did a good job. Your team, I would compliment you that you were able to pick up, Normally, what happens is like I had, in fact, that was also a referred case from RML, that child was sent to me saying that it is MDR extrapulmonary TB because the child was on ATT and was not responding and developed generalized lymphadenopathy. So the only thing during my OPD, I just asked the grandmother that is there any other problem with the child? So the grandmother said कि इसको दौरे भी पड़ते हैं. So it just clicked my mind कि it could be because of phenytoin. तो मैंने कहा कौन सी दवाई देते हो तो उसने अपने झोली में से निकाल के वो फेनिटोइन की शीशी मेरे टेबल पे रख दी. So it just clicked my mind maybe it's due to phenytoin and got the test done. uh, Sent the phenytoin levels also because over here the tests they were all negative for MDR or TB. The the child had anemia, rest CBC was normal, with slight, SGOT-PT were raised. Uh, and finally, the diagnosis was that the child who had phenytoin toxicity because the blood levels of phenytoin from AIMS they showed they had crossed the hazard limit. So the final diagnosis of phenytoin toxicity, then I suggested your HOD to just go ahead with a change of anti-epileptic because I'm not a neurologist myself. So shifted to sodium valproate, and finally the uh, lymph nodes they started to decrease in size. So we have to keep all the differences in mind, and that is what Dr. Urvashi is trying to guide us. That this is as a clinician when we are sitting, we have to keep everything in mind, and I would say that that was the precise reason Dr. Hema, your team was able to come up with added diagnosis of B cell ALL. So, yeah,
I would just like to add, ma'am, that most of the times all children with tuberculosis who are not improving are considered to be drug resistant TB. And in many parts of the country, even today, people do have this tendency and an enthusiasm to add drug resistant TB regimes without any proving that whether it is drug resistant TB or not. Most of the times it is confused with an iris reaction, as you said, with another reaction which may cause lymphadenopathy. And it is that this case has suggested that there are specific scenarios where you look for drug resistant TB and why this case did not fit. So actually starting off with the regime with drug resistant TB, once it is not proven, is actually very detrimental because the drugs are so toxic, it requires so much of things. So the message is that we should prove drug resistant TB,
yeah,
and we should see that there is no alternative diagnosis before we start all these regimes. So they are
yeah.
misused actually.
I totally agree with you. Because labeling as probable MDR and then starting in MDR TB treatment and the patient not responding on the MDR TB treatment, and that's the time they're totally confused what to do. So I totally agree. We need to do our level best. We all agree that sample collection is difficult in children. I always highlight one thing that please, because right at the outset, the chances of finding of getting microbiological confirmation they are highest, and we should always try all relevant investigations, the specialized investigations which are available to us to arrive at a bacteriological diagnosis, be it tuberculosis, be it any, and finally, as you suggested, even drug-resistant tuberculosis is, always review everything. Don't jump to start TB treatment. I would say in pediatrics there are hardly, I would say, there are two major conditions where you are justified to start ATT without microbiological confirmation. One is differential of partially treated bacterial meningitis or TBM, because both can mimic each other. And second is miliary shadows. Miliary shadows, they also carry a differential, but we are still justified. Even if you do not get your microbiological confirmation, you've tried your best, you send the respiratory samples and they come negative, you are justified to start ATT. But rest all would strongly advocate that we need to have a good follow up these patients, so that we may not be missing something else. So a very interesting discussion which is emerging, I must say. Are there any other questions?
No, there are no more questions.
Dr. Lok wants to ask.
A very interesting case, Dr. Hema. I just have one question actually. In the third time when the child was admitted to you, before admission, we have started the anti-TB treatment for 2 months actually. On the third or fourth month, child was admitted. At that time, the CNS, as in this case, you write down CNS was within normal limit. So I just want to know, is there symptoms of compressive myelopathy was improved when the child was admitted at the third time after taking the ATT of I think 3 or 4 months actually, as you shift this child into the CP phase. So, and the child was also lost to follow up for I think 2 months. So at the end of when the third time child was admitted, is there a sign of compressive myelopathy or improved?
Dr. Gayatri wants to answer. Please answer.
Dr. Gayatri, you're muted. You're not audible.
Ma'am, am I audible now?
Yeah,
Yes.
Sir, so after the second admission, actually a repeat MRI was done around 2 months, and the onset of symptoms was 3 months later. Like around 5 months later is when the child reported to us. So after 2 months, there was a repeat MRI which was done, which is not added in this. That showed an improvement in the symptoms with improvement in the compressive myelopathy, sir.
Dr. Hema, you're muted, ma'am.
Even clinically, the child improved. The symptoms of myelopathy were not there when the child was again readmitted with worsening of symptoms, sir.
Symptoms was improved basically, no?
Yes, sir.
Yes.
So you attribute this to tuberculosis or to malignancy? Because they are improving, that means that it is due to TB, due to tuberculosis.
Ma'am,
Looks like,
since
ma'am,
we have
because after 2 months. Yeah, okay, Dr. Gayatri, you can answer.
ma'am, since we have a positive microbiological evidence with drug sensitivity, which has improved over 2 months, I think we would attribute it initially to TB itself, because the child improved symptomatically, showed improvement over the course of the initial phase, and child has returned later. So I think, ma'am, we attribute it to TB itself.
Thank you so much, Dr. Gayatri. We can go ahead with the directives from Dr. Komal.
Yes, ma'am.
Good afternoon, everyone. So now myself, Dr. Komal Attri, senior resident, and as we have discussed the case of disseminated COX with B-cell ALL, now continuing forward this discussion, we will discuss about drug-resistant tuberculosis, a miss or a misdiagnosis, and TB and leukemia masquerading and coexistence. So first, discussing about the burden of drug-resistant tuberculosis. Among the newly diagnosed cases globally, 3 to 4% are MDR or rifampicin-resistant TB cases, and among the previously treated cases, 18 to 21% are MDR or rifampicin-resistant TB cases. In 2023, 5 countries accounted for more than half of the global number of people estimated to have developed MDR, out of which India had contributed to 27% of them. According to the WHO Global TB Report of 2024, the estimates of MDR and rifampicin-resistant TB in India have reduced by 20% from 2015 to 2023. Discussing about the burden of MDR in children, MDR TB remains a public health crisis and a health security threat. There is very limited data available for India. In India, only 3% of the total MDR TB patients detected were children. And as per the modeling estimates, out of 25,000 to 32,000 children who develop MDR globally, fewer than 5% are diagnosed and receive treatment every year. So, child and adolescent TB often goes unsuspected by healthcare providers and is difficult to diagnose and treat. So, this is a disease forecasting model. In the absence of any drug resistant TB intervention, drug resistant TB cases will eventually increase in the community. And with appropriate diagnostic and treatment interventions for both sensitive and resistant cases, the outcome is improved and we can see less number of cases in the community. Increased community transmission and mortality due to untreated DRTB needs to be addressed with effective management steps, which include early identification and treatment of the index TB case, whether it is resistant or sensitive. There should be screening of household contacts for the disease, and TB preventive therapy should be provided to the eligible household contacts. Now discussing about the community transmission of drug-resistant TB, how it works. If we have an index case of a sensitive TB, drug sensitive TB, there is about 3% prevalence of TB disease in the household contacts. And if each patient is causing 10 secondary infections annually with appropriate diagnosis and treatment, there is 80% cure rate, which will eventually lead to fall in the total number of drug sensitive TB cases. But if our index case is a drug resistant TB case, the prevalence of spreading of the MDR TB in household contacts is 5 to 8%, and out of which only 3 to 4% will be diagnosed and treated. And if each case causes more than 10 secondary infections annually, and if there is delay in diagnosis or treatment or follow-up, eventually in the community there will be increased number of DRTB cases. So drug-resistant tuberculosis comes with a spectrum. In this, we have monoresistant TB, polyresistant TB, MDR TB, which are resistant to R and H both with or without other first-line drugs. We have pre-XDR TB with MDR TB plus resistant to one of the fluoroquinolones, and XDR TB, which includes pre-XDR with resistant to one or both additional group A drugs. So if we have a patient on ATT having persistent symptoms or new symptoms, we will always first think about poor drug compliance, or there is inadequate drugs which are going to the patient. We'll check about the duration, dosage, and the absorption of the drug. Or we can also think about drug-resistant tuberculosis. Other than this, we can also think about paradoxical reaction due to ATT, or patient may have any underlying secondary complication, which could be any superimposed fungal or bacterial infection, or an unmanaged secondary complication, or patient could be a case of severe acute malnutrition or inadequately treated SAM. Or it could be a diagnosis of malignancy or connective tissue disorder, which is masquerading as tuberculosis. So, when to suspect drug-resistant tuberculosis? If we have a patient who have clinical and radiological features of TB, we should always go for bacteriological diagnosis, as no clinical or radiological pattern can differentiate between a drug sensitive and a drug resistant TB patient. And we should always go for upfront microbiological testing and always check for epidemiological markers by eliciting a good history. Drug-resistant tuberculosis is related to certain epidemiological markers, which are history of contact with the suspected MDR TB patient. The patient is lost to follow-up after initial treatment. or there are details of any previous poor treatment or inadequate drug dosage or duration, or there is lack of adherence to the treatment, or a patient living with HIV or those in contact with someone dying of TB, or any non-responder to the therapy, or there is recurrence of disease after the previous treatment. As the case we have discussed, in that case, the patient was having recurrence of treatment symptoms after the previous treatment. So the either it could be a drug-resistant TB case, or it could also have been something other than tuberculosis, like any untreated coexisting or intercurrent co-infection. So, drug-resistant tuberculosis can also present without any epidemiological marker, as in this case of primary extrapulmonary tuberculosis in an immunocompetent child presenting with pleural effusion. Only bacteriological testing confirmed that it was a drug-resistant TB, and there were no associated epidemiological markers. So, we should not start the treatment for MDR without any microbiological evidence, and all efforts should be made for a microbiological evidence, as drug resistant TB can also present without these epidemiological markers. Now, thinking beyond drug resistant tuberculosis, if a patient is showing fresh symptoms after starting the treatment, or there is worsening of the existing disease, we can also think of any whether it is a case of paradoxical reaction to the TB drug, or there is underlying superimposed infection, or it is something else which is mimicking as tuberculosis. So, discussing about paradoxical reaction, if there are any physical or radiological signs in a patient who previously showed improvement with the treatment with appropriate ATT, or there is expansion of existing tuberculoma or development of any new brain lesion, which is reported as early as 2 weeks or as late as 18 months after the initiation of ATT, it could be a case of paradoxical reaction to ATT, but it is always a diagnosis of exclusion. Discussing about superimposed or concomitant infections, Atia et al. Reported 33% of active pulmonary TB with a bacterial co-infection in 137 adults. The most common among them are Klebsiella and Pseudomonas species, and rarely we can also see Salmonella typhi and Streptococcus miliari. Fungal co-infections with TB, the most common are Aspergillus niger, Aspergillus fumigatus, Histoplasma capsulotum, and Cryptococcus neoformans. Aspergillus infection mostly missed in a patient with tuberculosis because of the similar clinical features and lack of clinical suspicion. Concomitant pulmonary TB and invasive aspergillosis, though very rare in immunocompetent patients, it should be suspected when a TB patient is clinically deteriorating, because aspergillosis develop in the cavitatory lesions of TB and it causes worsening and clinical deterioration in the child. Now, discussing about the disease which can mimic as tuberculosis, we have infectious causes and non-infectious causes. In infectious causes, we can have aspergillosis or nocardiosis, and in the non-infectious causes, we can have sarcoidosis and leukemia. Another pulmonary nocardiosis closely mimics chest TB radiologically and clinically. Thus, it always requires microbiological confirmation for the diagnosis. Discussing about another mimicker of chest TB, we have sarcoidosis, which imitates TB clinically and radiologically, but biopsy distinguishes the non-caseating granuloma. Now discussing about spinal TB, there are cases reported in the literature which shows that aspergillosis infection can also masquerade as spinal TB. As in our case, the patient was diagnosed as a case of port spine with epidural abscess. We could also be think of diagnosis if we have to think of diagnosis other than tuberculosis, we can have aspergillosis. We should be considering these mimickers when patient is not improving. Now discussing about TB and leukemia. TB and leukemia are distinct yet very overlapping disease, and malignancy masquerading as TB and TB coexisting with malignancy is very well known. It is always a clinical conundrum that whether it is a TB or a malignancy, because they have similar symptoms and signs. like fever, night sweats, weight loss, prolonged productive cough, hemoptysis, chest pain, anorexia, and signs of pallor with lymphadenopathy with pleural pericardial effusion and ascites. And in the imaging, both can present with chest X-ray findings of mediastinal widening and pleural effusion, and in CT, we can see caseating granulomas in both of these diseases. So, tumor-induced TB is very well documented and reported in the literature. And the reason behind this is the chemotherapy and the immunotherapy started for the tumor can cause immunosuppression and leads to reactivation of the tuberculosis or can altogether lead to a new infection. And there is alteration of cell-mediated immunity due to tumor cells, which can also lead to tuberculosis. But TB-induced tumorigenesis is still a hypothesis. And the main mechanism which lies behind this is that in TB, there is chronic production of inflammatory mediators. And TB also induces M2 type macrophages that aid tumor growth. It also stimulates EGFR mutation. And TB infection cause direct DNA damage and apoptosis inhibition, which can lead to tumorigenesis, but it is still a hypothesis. So there are various case series in which we can see concomitant TB and malignancy. This case series highlights that TB and malignancy can coexist in the same lymph node, posing a diagnostic challenge, and it always requires combined treatment. TB and lymphoma can also coexist in the same lymph node, making the diagnosis challenging and require very high index of suspicion. So the take-home messages from this discussion are: if we have a patient who is not improving or worsening on first line ATT, it needs thorough evaluation before starting the drug-resistant TB regime. All efforts should be made to get a microbiological evidence for the disease, and alternative diagnosis, co-infections, and other complications must be considered. We often seek a single diagnosis, but two distinct diseases can also coexist. Thank you.
Thank you so much, Dr. Silver. It was quite a descriptive directive you have given. Dr. Hema, can you please give your expert opinion on this after summarizing this whole case?
Okay. Firstly, thank you to NIT RT for giving us the opportunity to present this case. The main aim of presenting this case was not to confuse, but to lay important on two things. That one, microbiological isolation of tuberculosis should be done before starting of the anti-tubercular drugs. So pediatric TB is difficult because the samples may not be there. Sputum is difficult to get. So it is always good to start on before we start the therapy to know whether it is risk sensitive or risk resistance and whether it is tuberculosis or not. And secondly, when we talk about a non-improving patient, then many of the hospitals, even in tertiary care settings, we see that people are enthusiastic to add on drugs like levofloxacin, then add on drugs linezolid, which are available over the counter, and label it as a drug-resistant TB. But before labeling it as a drug-resistant TB, we should be thorough with our diagnosis that whether we are dealing with drug-resistant TB or it is something else, because there can be multiple masqueraders of tuberculosis in pediatrics, which can be both infectious conditions or it can be both non-infectious conditions. So the main motive over here is that for drug-resistant TB, there are certain markers which can be there, especially in pediatric, where the patient would be running down fever, the patient would be not able to, weight gain is not there, the patient would be toxic. It is not that the patient is afebrile, running here and there, and you can think about drug-resistant TB. So drug-resistant TB should be thought in valid settings and it should be proved before going to the drug-resistant regimes, because if you don't prove that and you start on the regimes, then maybe it is a misdiagnosis or you actually, we tend to misuse the regimes which are there. So the motive of this case was just to sensitize with this and not to confuse it with malignancies. But yes, malignancies and other things do masquerade tuberculosis in pediatric settings as well as in adults. Thank you.
Thank you so much, ma'am. It was
Thank you. Very good.
Now I'll call Dr. Sangeeta Sharma, ma'am, for her expert opinion as she's an expert for the case.
I think Dr. Hema has discussed, and I totally agree with the essence, because I feel we pediatricians, our mindset needs to change, because with the advent of these newer diagnostics, NAT, which is readily available. Now it's available even at the sub-district level. And with the TrueNat, with the availability with our leader, the team, Dr. Urvashi Singh, now we are, expanding the diagnostic network, and we are also expanding the samples for children. So, as has been highlighted, we need to try for the microbiological diagnosis right at the outset and not jump to treatment, uh, uh, keeping care that we are not wasting time either. So I would strongly advise after the diagnosis has been made to also keep an open mind, because as has been highlighted in this case, that there was a microbiological diagnosis. It was a rift sensitive tuberculosis, and despite that, the patient also had acute leukemia. So we also need to keep all these things in mind and treat the patient as a whole. I feel our mindset as pediatricians seriously needs to change. Any comments, Dr. Urvashi, your final remarks? Because I would like your input also.
Thank you, Dr. Sangeeta. A wonderful case selected and a very good presentation. Clinical management as well. I wanted to know how the child is doing now.
Yeah, even I wanted to know that.
The child is in chemotherapy, ma'am.
अच्छा chemotherapy. और
Yeah.
ATT भी चल रही है.
ATT we continued, ma'am, and the child is on chemotherapy.
And the child is improving now.
Yes, ma'am.
You have said the CNS symptoms, they improved despite, there was a gap in ATT. The child had defaulted, and the third examination, the third examination which is shown in the case, that there was CNS was normal. That means the compressive myelopathy had improved.
There was no gap in the ATT. The compliance was good. That is why there was a query which came up: if the compliance is good and the child is taking treatment, then how is the child developing additional symptoms? So the child was on ATT, compliance was good, and myelopathy also improved in the third admission.
Okay. So the CNS, the compressive myelopathy was gone.
Yes,
So
it
now
was only the firm lymph nodes and the firm hepatosplenomegaly which were a clue that yes, it was now a malignancy.
Okay. Good. Okay.
So two things, Dr. Sangeeta.
Yes,
Three things. The first, when we know the child is immune compromised, the ATT duration can be increased. You see, it's not ATT alone that takes care of the bacteria, it is the immune response as well. So do not be in a rush to stop the ATT. That has been our experience with patients who were put on immune suppressants for other illnesses. Now here the child has the immune system knocked off because of the malignancy and possibly because of the other treatments as well. So think before you stop the ATT. Maybe you can discuss with Dr. Sangeeta or us, Number two, like I mentioned earlier, Dr. Sangeeta, you're the best person along with your team of experts. I feel that a scan somewhere would help in the algorithm. Again, I'll leave this to you. Thirdly, when you went into the bronchos with a bronchoscope, whatever material whether you're collecting a bowel or you're collecting a biopsy, I would feel that it is a pressure sample collected invasively, could have been also tested for, an FNAC kind of a thing or histopathology. Especially because you see, this may be just the tip of the iceberg that we are catching. Coexistence of TB along with the, other carcinomas also is, we are, getting to know more and more of it. One leading to another or one predisposing to another, it could be a two-way road. In adults, we have several reports. In children, when we are going into the bronchoscope, I see no harm in doing one extra test when it is a pressure sample. So these were my 3 points, and we would love for the child to become better soon. And we'd love to hear from you, Dr. Hema, as to how the child is performing. But I reiterate, ATT can be extended in such cases. Thank you.
So, ma'am, point well taken.
I agree with all the 3 points that are totally relevant to this case, Hema. At the end of 1 year, please review the child for tuberculosis also. Although the case is not transferred to the hemato-oncology department, because as has been highlighted, we may have to, in special circumstances, depending upon the disease, even I would say MRI of the brain also, because you were not able to do the CSF. So, because of the compressive myelopathy. So, all these things, please keep it in mind. And now over to you.
Yes, ma'am. So thank you so much, ma'am, Dr. Hema, ma'am, and your team. It was a wonderful case, and we learned a lot. And yes, like likely said by presented by Dr. Komal, yes, TB and malignancy they coexist. In adults, we see it more commonly. One thing I just want to put up my point in adults, whenever we see a case of pulmonary effusion, tubercular pulmonary effusion, we always send the samples to ADA. Like I was also discussing with Dr. Sangeeta, ma'am, she was like, we don't suspect malignancy so frequently in children, so we do not send ADA samples. But yes, that actually help us to decide whether we are going towards tubercular. Though your case was totally micrologically proven, so there was no confusion left in this case. But yes, ADA at times does help us to further investigate the child if the ADA is there. It is not a diagnosis of tuberculosis, but it does help us to further expand our diagnosis or further workup of this patient. And the carry away.
I will beg to differ. We have more sensitive and specific tests than ADA. So, frankly, ADA used to be a test for the yesteryears. Today, we do not really recommend it because it can actually cause confusion. It may not always be raised. So, I am of the opinion that it can be part of an algorithm, but definitely cannot be depended upon.
Totally agree with you, ma'am. Your point well taken. But what I mean to say is just in cases where we need a confusion, the low ADN when they're starting with tuberculosis, it definitely click us into mind that we should investigate the patient further if the ADA is low. So that was the only point why I was making it here.
Yeah.
It is definitely a diagnosis of tuberculosis.
Historically, it has been helpful, but now the world is moving towards more sensitive and more specific techniques. So, I would like to also bring that up that this is not 100% dependable. In fact, if you look at the sensitivity specificity, I mean, it's below what we would recommend it as a routine.
Totally agree with you, ma'am. Definitely.
Sarojin, children, as I discussed with you, the next differential is bacterial pleural effusion. So in that case, also the ADA will be high.
Yes.
So normally that is one of also the reasons that ADA is not recommended. You do it as first line for your adults, but for children we do not do it normally.
Right.
It's only when the child is not improving and there is a rapid filling, short filling time, that there is a rapid progressive massive pleural effusion that we think of malignancy, and that's the time we do get an ADA done. So our guidelines in that way, even for CSA, we do not recommend ADA. So, but
yes,
yeah.
So with this, I think we are at the end of the clinic, and for that, I will request Dr. Ashok Bhardwaj, sir, chairperson of the National Task Force, to deliver the closing remark. Sir, over to you.
Thank you. First of all, I must thank Dr. Hema and her team, by Gayatri and the other, I forgot the name. This is an excellent presentation. I have yet to see such presentation in this the history of pediatric, at least pediatric difficult to teach clearing. So thank you, madam. Thank you. So it was very informative. So I will elaborate on the comments of Madam Urushi, Madam DDG. So we should not forget the diagnostic algorithm, and we should keep everything in mind. So thank you, Madam. Then Dr. Alok, Dr. Sroj, led by Dr. Sangeeta. So, excellent critical analysis of the case. So and the didactic. So it was very informative, the didactic. And but last, I am sorry that today's attendance could not touch 80. I am sorry for that. I sent email to everybody wherever I could send. But again, in the further also I will try to send email to pediatricians so that because pediatricians are to be benefited because they are the people who have to follow the guidelines and to do something, because if we go to the peripheral level, people are totally ignorant of the guidelines. So this is a tertiary level institution. There is no problem, but we are concerned about the peripheral level. So more and more pediatricians should join these CME programs, the difficult to treat cleaning, so that they are benefited by it. So I will further try again and again so that more people should join. So thank you, Sangeeta madam, for giving me a chance, and thank you, Dr. Hema and your team. Wonderful. Thank you.
Thank you, sir. Your words of encouragement, and I need support now because even I'm disheartened a bit, because our account did not reach three figures this time. Although it was one of the best presentations we have had till date.
Yes, yes, yes.
Totally, with folded hand, request Dr. Urvashi to either, make it the mail sent to the district TB officers, the state TB officers, because these are the people who will also benefit, they have children, they have to see children in their clinics. And also, sir, again, a request to you, because the medical colleges, the PG students, the undergraduates, because, tuberculosis is so common as we have seen in this case. It can be there with anything and everything, and we need to increase our knowledge, and this is a platform where we are learning from each other. So, with this, I think I would say that call it a day for now and meet next month, same third Tuesday, 2 to 3 p.m. So thank you, RML team. Yeah, and thank you to all who have joined in. And you're a source of encouragement to us. And please, I would request any of those who are, joined in, they want to present any case. I mean, although we have already a list which is prepared, but as in this case, Dr. Hema, she met me in a conference and she requested me, ma'am, एक बहुत interesting case I would like to present. So, I mean, we just I tried and we were able to fit in her case because the kind of request she was doing, I could not resist. So I said, others जो line वाले वो आते जाएंगे. So same is true for others who are logged in. Anybody who wants to present, please, you have our email. You can email us, and we are all here to learn from you. Your interesting cases would be eye openers even for us. So thank you all for joining in.
Yes, and with this we end this clinic, and please do share your feedback so that we can further improve clinics.
Post-test
and post-test also.
Please complete the post-test, pre and post-test, so that we know that how much this session was useful for you.
Thank you.
Thank you. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you.